I'm sure you've heard before that good quality CBD needs to be really, really expensive. This is the new view of CBD, a product created by users for users, a product at an affordable price, available everywhere, at any time, at the simple click of a button. Just CBD and MCT oil, no additives, no preservatives, and no flavor enhancers. It's a simple subscription-based service, the cleanest possible CBD delivered to your door for the lowest possible price. Your product, your rights for the lowest possible price.
That's like proper TV.
It's amazing.
Wowza. That was so good. I should have, but I've never seen that before. I'm completely. Where did you get that guy? Who was he? He looks just like you.
He's just like me. Basically, I have this doppelganger who does like live shooting for me.
Amazing.
More reliable.
Well done. I absolutely love that. Hi everybody, I'm Russ Kane. On yet again another wet London day, but I know we've got people watching from all over the world. So wherever you are, I hope you're safe. Hope you're well. Hope you're happy. As ever, this is the Ollie Mammon Show, as I call it. I'm just here to hopefully ask the questions that you would want to ask Ollie. Our special guest today. Well, I'm going to let Ollie introduce him. He's a proper doctor.
What's up, everybody? Welcome. Sorry.
No, I finished. Go on.
Yo, what's up, everybody? Welcome to episode 6 of the ABC of CBD, hosted by myself and Russ Kane. And it is an absolute honor to be doing the show for all of you. This week, we have an incredible guest who has like a massive level to reach, because our last couple of guests have also been awesome. So loads and loads of pressure on the shoulders of Dr. Leon Baron, who's joined me and joined Russ. Dr. Leon Baron is a cannabis doctor, and he has this plan and he has this idea of how to make this market better. Now, my name's Oliver Mammon. I'm chief infusionologist at Taylor Mammon. My job is to create CBD products that actually work, products with an actual purpose. Now, Taylor Mammon, we're a white label manufacturer. If anyone needs CBD products, feel free to reach out to us. The show is sponsored by the Tincture Club. It's a brand which we create and manufacture, hence why my face was on the advert around a minute ago. But yeah, let's get into the show. So basically, I'm sure you're all aware that in the last 18 months or so, around 18 months ago, there was an announcement that medicinal cannabis is now available in the UK. And I'm sure you're also aware that CBD and cannabinoids in general are a very hot topic of discussion at this moment of time. However, there seems to be this fact that things don't seem to line up. So you have this medicinal care system in the UK now. So if you need medicinal marijuana, you can get it. And then you have CBD products all over the marketplace, but you're kind of left to fend for yourselves when choosing a product. Now, if you have this desire to go and speak to a doctor, or if you have this desire to maybe take your medicinal cannabis journey further, you are kind of limited in your choices, even though we have a legitimate medicinal marijuana service and system in the UK, which kind of runs alongside other medicinal systems in the UK. But we're all left a little bit in the dark. So today's episode is to kind of focus a little bit more on that, to understand a little bit more about, legal cannabinoids, to discuss with Leon, different caregiving options, to discuss with Dr. Leon the general marketplace and what his plan is to try and create a more consistent, reliable system. And I think the key word for today is access. Access to actual medicinal cannabis is very limited. And there is this belief amongst some people in the medicinal community to try and create easier access. And I believe that's what Dr. Baron is all about. Now, one of the biggest issues in our industry is the demonization of cannabis. And I find that this demonization isn't just with users. So I had a phone call today with someone who actually called up to ask about the Tincture Club, and I had a little chat with her. And she was like, there's none of that other stuff in there, is there? And I was like, what other stuff? And she was talking about THC, real cannabis. And I was just like, look, you've got to go and watch the videos, because the first thing I'm trying to educate everyone on is the fact that it's not CBD and THC, it's not hemp and cannabis. They all come from the same place. And it's about knowing full well that each individual compound has its desired application, and every single compound has its purpose. And I believe Dr. Baron, that's what his plan is, to kind of educate and inform doctors on how to understand what cannabinoids actually do, and to kind of create this system of education and understanding amongst a medicinal system which is already in place. Now, you know, whereas CBD might seem like a white market product, in reality, if you go to your doctor and you say, look, I take, you know, 400 milligrams of ibuprofen every single day because I have inflammation issues, your doctor is very unlikely to suggest CBD as a compound, even though CBD is so widely available. Now, I'm not saying they should give you a prescription, but there should be a little bit of understanding and communication with the general hierarchy of medicinal understanding, which is, you know, which kind of umbrellas the UK. So, you know, if you as a user feel left in the dark, we kind of don't really have any places to turn. And Dr. Barron's aim is for us to be able to turn to the people who we've always turned to for medicinal advice. And Dr. Barron's aim is for us to be able to turn to people like him, who are real doctors, as opposed to you having to turn to people like me who just make products. Now, don't get me wrong, I'm great at what I do, but I'm not a doctor. You know, like I say it over again, I'm not a doctor, I'm not a scientist. I'm just a dude who makes products. And I forced myself to understand what different compounds can do and what, you know, CBD can do with other added ingredients. But a general system is very far from being a reality. And people like me can't be responsible for your health. You know, the health system needs to be responsible for your health, whether it's guiding you or prescribing you. So yeah, that's basically a summary of what we really want to talk about today. You know, like, it's mainly to kind of give users of legal and illegal cannabinoids more of a fighting chance when trying to find something which is for them. And in all fairness, it's not fair, but this is just the beginning, okay? And like I've written on my notes here, have no fear, Dr. Leon is here. So it's not about leaving you guys in the dark. It's about shining a torch on the positions where you are right now. Don't laugh at me. We're live. Everyone can see you laughing at me, and it's not fair.
I'm laughing with you. That's entirely different.
Putting a lot of pressure on me, Ollie.
I'd go like that, you see, if I was laughing at you.
But to be honest with you, Doc, you know why I like putting pressure on you? Because I'm in the trenches with you. And fact of the matter is we don't think I've put a hell of a lot of pressure on myself trying to do this show on a weekly basis and trying to educate the people out there. But having people like you by my side, or having people like me by your side, at least we get to create a unit of people who are actually trying to help people find what they need from this plant. That was an awesome introduction. Let's just dive straight in. So Dr. Leon Baron, who are you and what do you do?
All right. Thank you, Ollie, for that wonderful introduction. Listen, just to put it all in perspective, all in context, I'm not I'll say this outright. I'm not a cannabis doctor. I'm a GP. However, I've got a very strong interest. I've got a very strong interest in cannabis-based treatments and medicines. And I guess what I'm trying to do is find a way to combine that interest in cannabis-based medicines and bring that into my work and into the wider work of GPs and within primary care. Because that's really where I'm placed. I'm not a specialist. I'm a GP. I'm a generalist. And so, yeah, I mean, look, my day job is I'm a jobbing GP. So I've just literally finished my clinic today. And
how was it?
It was all right. It was busy. Unfortunately, with COVID is picking up again, but that's another conversation.
Can I jump in? I've got so many people who want to know this because we discussed this on the other shows. But while I've got you here, and it's slightly off piece, forgive me, Ollie.
That's fine.
Is your don't say where your surgery is. Please don't say where your practice is. It's somewhere. Is it open? Because mine remains closed.
It is open.
And they're not planning to reopen. You can phone them, but you can't go in there.
No. We have look, when COVID took hold earlier in the year, they had to act quickly and they had to do something to stop unwell people just coming in, sitting in the waiting rooms, spreading viruses. What we have now in my particular surgery, I can't comment on some of the others.
Of course.
is a telephone triage system. I'd say 3/4 of the clinics are telephone triage, and then there's 4 or 5 spaces to see people face to face. So actually, from my experience, Russ, what I'm finding is most of these problems I can deal with over the phone. Particularly younger patients, they'll send me send photos of rashes or swellings or what, or we do a video consult. And Ollie, keep it. And if I need to bring people in, I've got a few slots that I'll bring them into.
Okay.
So in my practice, we have reduced significantly the face-to-face contact, but we will always see people. We still do home visits. Nursing homes are seen, ward rounds in nursing homes. So yes, things have changed, but
Thank you. It's
we
just
certainly not shut the doors.
it's such a hot topic.
And also,
and
a lot of people are don't want, and a lot of people don't want to be coming in at the moment. I mean, we read about the patients that are unhappy, which is understandable, and I do get that, but most people that I'm dealing with are quite happy not to be coming in and sitting in our waiting rooms. So yeah.
Okay. Thank you.
All right. No problem.
Back onto cannabis.
Back on the cannabis.
Fine.
Okay,
Why
so
did you say you're not a cannabis doctor?
Because I'm not. I've never prescribed cannabis.
But has any doctor in the UK ever prescribed cannabis?
Yeah. A lot of doctors are now prescribing medical cannabis products. A lot of specialists in private clinics, and even those doctors would not describe themselves as cannabis doctors. And
Exactly. That's what I was going to ask.
And actually, I think this is a good point of discussion, because I've always seen cannabis. Well, the more I've got to learn about cannabis-based medicines and their application and where they could fit into conventional clinical medicine, I think they should be treated in the same way as any other unlicensed medicine is treated, or any other medicine. So, I don't really think we should personally there's a need for cannabis clinics. I think ultimately cannabis should be another tool in our box that we can prescribe if we understand it as individual doctors, if we've had the appropriate training in prescribing. And I think it's a wonderful addition to what we use already, or an alternative. And I would ultimately love to see a system whereby GPs are seen as the main prescribers and products are accessible through the NHS.
Unlike a standard pharmaceutical product, which never changes, you're expecting, so you have a doctor, and the doctor gives you a prescription which they send over to your pharmacy, and you go and pick up your prescription. Okay, are you saying that that's the sort of system you want to have in place?
Yeah.
Where basically you go and see a doctor, and the doctor has so much knowledge and understanding of cannabinoids that they can look at you, speak to you, and be the same way that they say you need ibuprofen for your muscle inflammations. You can turn around and say, actually, you need 5 grams of OG Kush, you need X amount a day administered in this way, vaped or smoked or taken in a capsule with this specific terpene profile and this specific blend of cannabinoids in order to affect that ailment. And fine, the one thing, so basically we've moved very far over, but what I don't understand is you have doctors who are being trained from a very young age. They train from 18, they become doctors when they're 24. And at this current moment of time, none of the training which happens with any doctor, none of the medicinal schools in the UK have any focus on cannabinoids. So they're being taught the foundation, the first floor, the second floor, and the third floor. And then you expect this entire understanding of a medicinal system to kind of be pushed to the side and the separate framework to be built alongside of it. I'm just trying to get an understanding of how you take something as specialist as cannabis and you bring it into a system which is already specialized.
This is exactly why we have problems with it, and why we have problems with access. So if to put it in the most simple terms, I like to think of it as the horse and the cart, and the cart at the moment is in front of the horse. We've come at this at a completely different angle to any other any other medicine that's been introduced into practice. So we've never, to my knowledge, had a system where, everyone knows better, if you like, than the actual doctors or the medical regulatory bodies, because we know cannabis is a wonderful medicine for many for many conditions, many reasons. Many patients, people across the world are finding, know about the medical benefits. Many of them have done for years and years, centuries. And what we're trying to do is fit that into our very conservative, but very, very high standards of UK medical care that we've all grown up in and we've all trained, that I've trained in. And it just doesn't fit very well. Now, the North Americans have found a way to do this, and obviously they have a big recreational market as well. And what you found, what you've seen in Canada or North America, where this has been present now for some years, is that you find that there's a pocket or a group of primarily GPs who are getting more specialized in this type of prescribing. So and often they're learning from patients as well, and they're learning as they go along. A lot of it's trial and error. We don't yet have the very refined treatment. We don't have what I would say are cannabis-based medicines that sort of behave like the single pharmaceutical agent. So it's a much more sort of general, looser way of prescribing, and that, you know, and I think that what you find when you speak to experienced prescribers is that they find that patients often need a little bit of trial and error. They try one product, it's not working, they change the ratios of cannabinoids, and they find that, you know, a child, for example, with epilepsy there's a different season or batch of the cannabis plant, and all of a sudden that product they've used doesn't work for them as well, so they have to switch to something else. So that's what we're dealing with. We're dealing with a botanical medicine that doesn't fit cleanly into the way that we've all been trained to prescribe, which is we go to our BNF, we look at the dose, we look at is this licensed for this, and then we confidently prescribe it. Now, that's not to say that many medications that we prescribe are unlicensed, and full spectrum cannabis products, which are essentially, they come from the whole plant and they're primarily issued as oil, given as oils or sometimes as flowers. They are classed as unlicensed, and this has been a big block to wider prescribing here in the UK. What's interesting is and I'll often say this to doctors or colleagues who raise this point, is that we prescribe a lot of medications unlicensed or off license. So you'd be amazed how many we prescribe on a daily basis in primary care in particular.
Can you give an example?
I'm talking about some opioids, for example, for certain conditions. Tramadol. Tramadol. I'm sure for non-neuropathic pain, it's not licensed, but it's very widely prescribed.
I can tell you, Leon, when I had sciatica, which I just wanted to shoot myself.
Okay.
The pain was off the scale, and they gave me tramadol, and
horrible.
within 3 days I was hooked. It was horrendous. I mean, it was absolutely horrific. I couldn't believe how powerful this drug was. The
synthetic opioids have been, I mean, they talk about the US having an opioid epidemic. We're not, I'll tell you, we're not far behind. The trends have improved a little bit. The last few years. There was a Public Health England report that came out a couple of years ago. 1 in 4 people in the UK are taking some form of addictive medication that is not in their best interest. It's either a strong opioid, a Z drug like a benzodiazepine, a gabapentinoid, so gabapentin or pregabalin, amitriptyline, zopiclone, sleeping tablet. There is a problem with prescribing. So, you know, when cannabis is given a bad deal in the press or amongst medical bodies, actually what we consider as gold standard clinical care is not, in reality it isn't, and a lot of patients are not, in my opinion, are not being managed properly, and they're being set up for problems with bad prescribing, lazy prescribing, and I think cannabis.
Sorry, carry on, finish, and then I'll cut in.
I think cannabis. The more I've learned about cannabis, and the more patients I've met or doctors I've met from overseas who are using it in practice, cannabis has a role to help with a number of different problems. It can help with deprescribing, with getting patients off some of these medicines. It can help improve quality of life. It can help improve sleep. It can help improve pain. It can help improve mood. And if you see the number of patients that aren't responding well to conventional licensed treatments, if you like, then there's surely a place for it in our system.
Why are they being
I mean, we can talk
prescribed?
about why it's not happened, and there's so much to cover.
Please,
really,
please do, because this is my big big question, Dr. Barron, is why are they being so difficult?
Also,
so obstructive.
Why are these dangerous drugs, which everyone knows is dangerous, being prescribed?
Because I think partly because, number one, 10-minute GP appointments, which we've had for years, are not conducive to proper medical reviews, proper thorough kind of holistic assessments. I think there's a sort of status quo. If this person seems relatively okay on this, my colleagues have prescribed it, they're doing well on it, let's keep them on it. I think an attitude of sort of anything is better than nothing. Some patients kind of come in with an expectation that they're going to get a script for something. The other big problem is that if we just focus on pain, because I think that's really one of the big complex conditions that cannabis can have a role in. In my area, if I refer someone to a pain clinic, it can take them up to a year to be seen.
Is this a cannabis pain clinic?
No, I'm talking about a pain clinic.
Normal pain clinic.
Any clinic.
Fine.
It can take up to a year for them to be seen by a pain specialist. Now, often you find the outcomes from these pain clinics are not brilliant. So in the meantime, while someone's waiting to be seen, what do? They come back to see us, either myself, my colleagues, and pain is subjective. If someone's in pain, then you've got to try and help them with something. So listen,
here's a comment, Dr. Barron. Here's a comment now. One of our viewers was watching from Spain, called Chrissy Holt, and she loves this show, and she's just said, I'd rather use cannabis oil or cream on my arthritic knee than take ibuprofen. It works much better without affecting my stomach.
Yeah.
So there you've got somebody who is an exemplar of with pain, with arthritis, and is living walking proof that it's effective.
Listen, the other thing to say, Russ, is that there's so many stories. There's so much anecdotal evidence out there for cannabis. However, I must say that it's not right for everyone. And actually, I think if you look at the way the private clinics are operating in the UK, there are strict assessments, there's kind of strict criteria, and actually some patients might not find it effective. It can work in quite subtle ways. So it isn't a magic bullet, but it just can help with
Oh, he's frozen. It's very interesting.
It's incredible, no?
Oh, you're back. Great. You froze for a second there. Can you hear us now, Leon?
I think, yeah.
You froze. You dropped out just for a second there.
Can you hear me?
Yeah, we can hear you perfectly. How far are we behind? Because this is a big subject on men's radio generally, and Ollie knows this. I keep going on about the opioid crisis in America, which kind of gets overlooked in the UK. But how far are we behind that? Because I think it adds to the strength of Ollie's argument and the way he puts forward his suggestions. That's why.
Listen, we're by no means at the level that they're at. I mean, they went through a time where oxycodone, which is a synthetic opioid, was literally being given out like sweeties.
Yeah,
there has been there's been a push to stop that kind of prescribing. But there's a lot of patients with particularly with chronic pain, or elderly patients who, they're on strong patches or some of these synthetic opioids, and it is a problem, but it's not. We're not there. We're not at the levels of the US, and we have pulled back a bit. But listen, there's talk at the moment. I don't know if it's only in its draft guidance. So nice guidelines which kind of govern our prescribing and our care are talking more about removing opioids from prescribing, but they're talking about removing over-the-counter codeine and other things like that. So actually, if anything, it looks like we're going to have even less to prescribe if these come through. Well, it is good in some ways, but you can't take something away from someone and not give something back.
You can't leave them in pain. You can't leave them in pain.
Fine, but this is very important to understand. what you're providing people.
Well, the things that we're looking at referring to. I mean, people talk about CBT and supervised exercise programs and things like that. I mean, you've got to be realistic about some of these treatment pathways. At the moment, we don't have the capacity in our community mental health services to refer a lot of our patients are on very long waiting time. So to get someone referred for CBT for chronic pain I think is going to be very difficult to see positive outcomes in that sense.
Now, while we've got a proper bona fide doctor on, let me pose this question for another of our regular listeners, Julia Hersey. Hi, Julia. I've read it interferes with liver metabolism with certain drugs, i.e. blood pressure tablets. What does that mean, interfere with metabolism exactly?
So I assume we're talking about CBD products. There have been some studies where liver enzymes have been slightly elevated with very, very high doses of CBD in epileptic children. The carrier oils in those cases were in alcohol, so that's possible reason. And I think overall, if you look at CBD, there's very limited evidence that it affects like liver function. It would be sensible if you're taking it regularly to sort of thing to perhaps keep an eye on, but to my knowledge, it's the sort of doses that people are using over the counter are not going to be detrimental. Blood pressure, there's very little that CBD will exert on blood pressure. High THC content can cause a faster heart rate. So anyone with unstable heart conditions should really stay away from it or speak to a doctor.
I've got to interject quickly. Okay, just very quick. I've got to interject. You said something before, and I don't like it, and I've got to kind of interject. You said before that cannabis isn't for everyone. Now, that's a very singular way of thinking, because it's saying that cannabis is a single thing which isn't right for everyone. But we know within a cannabis plant, there's 800 different compounds, 150 different cannabinoids, 150 different flavonoids, 300 different terpenes. We know that there's so many different compounds. Now, whereas, a high THC cannabis flower might not be perfect for someone, CBD might be perfect for them. And saying that cannabis isn't right kind of singularizes the plant, and you shouldn't, because fact of the matter is, within that plant there is something that will work for that person, even if it's just like a lemon haze terpene extract which they use because they find it chills them out or wakes them up. But there is some part of that plant which will agree with them. And it's like saying that pharmaceuticals don't agree with everyone. But there are so many types of pharmaceuticals, and there are so many different derivatives. It's really important, from a user perspective, and as someone who manufactures products, I've made products that are not right for some people, but I've made other products which are right for people. And it's important to know that dosage means everything. What other cannabinoids are included means something. Carrier tech means something. Whether, I know a lot of people who can't handle CBD drops. So what they do is they use belly button application, or they'll make suppositories. And what happens is they can handle it. They just don't like the taste. So they find a different form of application. And okay, let me finish, please. And the same is with like THC. It's like if you do have immense amounts of pain and you use a high THC, it might make you feel off. But if you were to take the same dose of THC and add in 4 times the amount of CBD, then what happens is a lot of the you could call it a lot of the not nice effects of the cannabinoids will actually disappear, because cannabinoids work with each other to get the best out of them. And it's about really understanding, what's right for the right person, and then never being a cannabis isn't for you, because it's not a singular, it's such a plural. And it's really important, because this whole education of doctors and stuff like that, it's the same way that you look at something like ibuprofen. Some people in the UK, recommended dosage for ibuprofen is 200 milligrams. Everywhere else in the world, recommended dosage for ibuprofen is 800 milligrams. So if you go to America, you buy ibuprofen tablets, they're 800 milligrams a piece. If you go to the UK, they're 200 milligrams a piece. Now, in America, they say take 3 capsules. In the UK, they take 3 capsules. So what happens is in the UK, you're taking a 600 milligram dose, which is right for us here. And in America, they're taking a 2400 milligram dose, which is right for them there. Now, I'm not saying 2400 milligrams is right or 600 milligrams is right, but what happens is the medicinal system prescribes what is right. And it's important for the medicinal system in the UK to understand that cannabinoids are so vast and they are so useful in such a variety of different ways that there's never this cannabis isn't for you. It's the right cannabis for you. And as users out there need to know full well that it's all about what's right for them. And they should never be in a position where they're told that cannabis isn't right for them because they have heart issues. You know what? Take 25 milligrams of CBD over 125 milligrams. Take 25 milligrams of THC over 125 milligrams of CBD, and all of those anxieties which you would have felt now disappear. But you still get all of the analgesic benefits of the THC, which you would be using anyway. And it's that sort of understanding, you know, that was completely theoretical, but it's that sort of understanding which we really need doctors to have. Now, in America, the cannabis pain clinics and the opioid pain clinics and doctors are 3 separate systems. You can't you can't walk into A&E and your doctor's like, you know, medicinal cannabis. You can't go see your local GP and they prescribe medicinal cannabis. It doesn't work. There's only one country in the world where your GP will send you on the route for medicinal cannabis, and that's in Israel. Everywhere else, you have to go to specialists. There's specialist pain clinics, specialist cannabis clinics. And I love your idea of educating and teaching within this system to kind of keep it as a formal practice. But how can we convince people who are so set in their ways to basically throw their rule book out the window and adopt this new way of thinking? And it's a new way of thinking which they've never had access to before, and the access they will have to it is so confined. Do you understand what I'm trying to say? Like, how do you make someone who doesn't want to do something properly?
Okay, so look, just to go back to my comment about it's not for everyone, I'm looking at this from a perspective of a GP, and I'm trying to do everything I can to bring my colleagues on board or work with some of the regulatory bodies out there or bring this discussion more into the mainstream. I think like any other medicine, I do appreciate that cannabis has almost unlimited potential for and the more we're discovering about the individual cannabinoids and the profiles and the ratios, then yes, some of these medicines will be tailor-made to patients in time. At the moment, we're still prescribing it in a fairly crude way, if we're completely honest.
Very
how
crude.
it's being
Terrible.
Prescribed. Like, you know,
wait, hold on.
I think
most people don't know how is it being
that
prescribed. Can you tell our listeners? Because I actually don't really know that
mainly
much.
Mainly oils and flour. So, you know, we're talking about high CBD, low THC, or balanced 1-to-1 ratio. These are whole plant. This is a mix of it. You know, this is a mix of all the. I know you've spoken about this in previous shows, Ollie, but all the cannabinoids, the terpenes, and you know, there's no. We don't really know kind of why that one might be working well for one person, but not for another. So, what I meant by my comment that it might not be for everyone, what I'm saying is some people.
Sorry, by the way.
I take the view on if you don't need something, you know, like if you're not having chronic pain or you're not, you've got like you only need a medicine or something extra if you're suffering or you're unwell or something else hasn't worked. And there are loads of other alternatives. You know, I'd start with paracetamol before I suggested cannabis-based medicines for patients. Start with ibuprofen, maybe for certain things. If you break your leg, you don't want cannabis. You want an opioid in the A&E department. Okay, so all I'm trying to say is some people out there have this misconception that I fancy that. You know, I'm not sleeping well at the moment. Let me try and get some of this cannabis-based medicine. We're early. We've got to tread very carefully with this. If we want to bring doctors in on this and treat it like another medicine, we have to work with it as a new medicine and try and find a way of fitting it in. Now, there are interesting things happening in that sense. So one of the reasons, I think this is worth talking about, but one of the big reasons why this hasn't just kind of been rolled out as like any other medicine that comes through is, first of all, it's unlicensed, which we spoke about. So it's not been, so these products have not been through large, usually very, very expensive clinical trials. Now, the gold standard for the pharmaceutical industry is what they call the double-blinded, placebo-controlled, randomized, double-blinded, placebo-controlled trials. Okay, where you have two groups of patients. You don't know what they're getting. It's either going to be a placebo or an active pharmaceutical agent, and then they'll do large studies, and they'll look to see if there's any significant differences between the two. These studies, first of all, they take years to roll out. Secondly, they're very, very expensive. And the majority of our drugs that we prescribe have been through this licensing system. There are also several that haven't. This is what the certainly NICE and NHS and the regulatory bodies look at for the sort of gold standard in terms of pharmaceutical drugs. This is what we've been working with the last 50 to 100 years almost. Cannabis will not fit well into this system. And the reason for this is that the oils and the whole plant products that patients are taking often have a very individual effect. Okay, so what might work well for someone might not work quite so well for the other person. The other thing to say is that the endpoints that are used in these large randomized control trials will often look at one single endpoint. Okay, so they'll say, okay, was there a significant decrease in pain scores by the end of our trial? Yes or no? Okay. Or was there, I don't know, often very finite, precise endpoints? With cannabis, what you find time and time and time again is patients who are using cannabis-based medicines do not see one major difference between X and Y. What you often find is much more of a subtle improvement in symptoms and day-to-day life. So you'll find that someone who's taking cannabis, the right type of cannabis oils, the right type of products, number one, they might be sleeping better. Number two, their mood is slightly improved. Number three, they're back in work because they're sleeping well, they're getting on better with their spouse, they're not as irritable. Their pain is slightly improved in that sense. So when you look at overall quality of life and different factors, you start to see a very much a different picture. Now, what's happening now to try and overcome this obsession with RCTs and cannabis? Because none of the big drug companies are.
What's an RCT?
The randomized controlled trials, which is the gold standard for the pharmaceutical industry. The pharmaceutical industry as a whole are not really investing, from what I know, in cannabis because.
Oh, we lost him at the juice.
It doesn't fit.
Right, because it doesn't. So you were just saying, sorry. Then the line froze.
It doesn't fit. It doesn't fit neatly into this sort of single agent, single pharmaceutical agent that you can standardize and you can run it through these types of trials. So what's happening overseas, where there's data being collected, is there's a big emphasis now on observational data. How can we look at patients over time and monitor them and then follow them up? And that data, it's been argued, is as valuable, if not more valuable in this case, than traditional RCTs. It doesn't mean it's not safe. It doesn't mean that adverse effects aren't reported. And what that gives us is it allows the most in-need patients to be prescribed products. It allows them to improve their quality of life. It allows data to be collected from them. So there's some amazing stuff. I mean, there's the 2021 trial that's going on at the moment.
Tell us about 2021.
So that's being run by Drug Science, it's Professor David Nutt, really, it's his project. And Drug Science are currently trying to recruit 20,000 cannabis patients through private clinics in the UK. And the treatments are heavily subsidized. And what they're hoping to do is build a very large body of observational data. So in fact, this week, the Outer Flora, who we've worked quite closely with through my primary care group, they've developed wonderful sort of symptom tracker for patients who are going into the 2021 trial. And if you look at what they're capturing, it's all those things I spoke about. It's how do you feel from a scale of 1 to 10 today with your sleep? How's your appetite? 0 to 10. How's your pain levels? And that's really valuable data. That's really important data. When you scale that up internationally, or you combine or even within the UK, you start to get a very, very strong body of evidence for this. And, I think that's really the approach that we need to take. And unfortunately, NICE, who sort of summarized all of their evidence and their view on cannabis last year, said, we don't have enough data, we don't have enough RCTs, we don't see any evidence that THC, for example, is going to help with pain. But the problem was they looked at this really through the eyes of the UK. And no, we don't have huge amount of data here because we've not been allowed to study cannabis. Well, go and look to Israel, go and look at Germany, who have got 100,000 medical cannabis patients. Go and look at the data coming out of North America and Canada, where there's thousands, hundreds of thousands of patients. Denmark, Denmark, who are just across the ocean, GPs are prescribing. They've got a compassionate scheme where they're running this pilot scheme where if someone is deemed by their doctor for compassionate reasons they may benefit from cannabis, they can get a script. Well, collect that data, use that data, build on it, and within no time we'll have a very, very large evidence base. So my view has always been get these patients treated, treat them, get them on the cannabis oils and follow them up, get the data. Sapphire, who I spoke to recently, they're one of the clinics in the UK. They're doing some interesting work. They're collecting a lot of data on their patients. So look, we don't have the ideal system at the moment because it's very much a two-tier now. We've got private clinics appearing. Unfortunately, the prices of the scripts have come down over this last year because they're allowed to import bulk product now. And so that's wonderful that the prices, they're still too expensive in my opinion. They're still unaffordable for most people, but they are starting to collect data, these clinics, and that will hopefully help to inform a wider conversation. And I think there'll be evidence to show that these medicines are cost effective, particularly when you look at the alternatives. I mean, look, I'm just going to talk about cost effectiveness for a while because this is an argument that comes up that they're not deemed cost effective by, they weren't by NICE. Think about an epileptic child who has very unstable epilepsy, and they've found cannabis oils to be effective in treating their seizures. Well, if you take a child off one of these medications, they before you know it, they're back in A&E, they're back in ITU, they're in hospital beds. Let alone the stress that causes on the family and the danger to the child. But how can you argue that these medicines are not cost effective when you look at the two kind of pathways that some of these children, and there's so many of these families now where the children are on cannabis oils. Some of them have had to go overseas to buy them. Some of them were up until recently arrested at the airport.
How much does a script cost? How much does a script cost in the UK? Let's say one of these epileptic children, they're buying something like Bedrocan or something. How much would it cost them? Bedrocan is a cannabis medication imported from Holland.
No, at the beginning of the year, the price, because of problems with bulk import, families were paying up to £1,500, £2,000 a month. There's been a shift in the law, and they're allowed to bulk import product now. So, from what I hear, most patients, depending on the product, it's a few £100 a month. I think of 300-400, so probably on average.
Here's my question. I got a couple of questions for you, Dr. Barron. I got a couple of questions for you. Zipping over to Spain for a second, where Chrissy Holt says, I buy my cannabis cream in the local health shop. If I wanted to take CBD, Oliver sells, is it okay for me to use? Well, yeah, sure. It is.
Yeah, I mean,
you wouldn't be a guinea pig, Chrissy. You'd be a customer, which is entirely different. Or have I got that wrong?
No,
Chrissy, I've made products for over 150,000 people. Okay, I mean, like literally in the last, over lockdown, we made something like 200,000 units. Okay, so I'm just saying you are definitely not a guinea pig. All right, but if you would like to be a guinea pig, feel free to reach out, Facebook me, and we can guinea pig the hell out of you. Also, Dr. Leon, I'm getting abuse from my fans here that you're talking too much and I'm not talking enough. So I'm just throwing it out there.
No, they're not. They're saying that this week Dr. Barron is outdoing him. Yeah, he's outdoing you.
Let me say something about CBD, because this is important, and this is a real conversation piece in general practice. CBD, over-the-counter CBD products, fall into a very grey area in medicine. So I'm sure, Ollie, you've touched.
I was going to bring this up to you, but you're not letting me ask you questions, so it's
Stop sulking.
That's all I have.
We can't really.
If an individual, so
can't
basically, fine. So me as a CBD user, all right, I know for one that CBD is widely available absolutely everywhere. And if I really wanted to, I can go into any shop I want. Literally 50 shops on every single high street will sell a product which is a CBD product of types. Now, let's say I find a CBD product that works well for me. If I want to go to my doctor and say, look, I found CBD, how does it work with my current medication? Your doctor will give you an answer. And they'll say, well, to be honest with you, check Google, but actually, it's quite counterintuitive, or it's not, or it's this, or it's that. They'll give an answer. However, if you turn around to your doctor and you're like, look, I'm not asking for a prescription. I'm not asking for medicinal cannabis. I'm not asking for you to pay for it. But I've bought this product and I now no longer want to take the opioid-based medication you've been giving me. The doctor will turn around and demonize the CBD and say, do not take it. Stay on the opioids. Don't do it. And if you are to do it, you're no longer a patient of mine. And that whole point is as users, they're very unguided. I'm not saying this is the standard, but I'm saying this is happening. You know what I mean?
This is partly why I put together my platform. So the Primary Care Cannabis Network was put together by myself and a few other GPs, essentially to try and educate and inform GPs about this subject matter. CBD, over-the-counter CBD products, whether we like it or not, are being used by a lot of our patients. I think there's an estimated 10% of the population have used or are using a CBD product. Obviously, they come from hemp, different type of cannabis plant, but essentially it's still cannabis. It's just fast growing. It's used for other reasons. But the CBD is CBD. So there's no difference between CBD in a prescribed cannabis-based medicine than a CBD in an over-the-counter product. It's just that some of the over-the-counter products perhaps haven't been through the rigorous process of GMP
but doctors
testing.
Still don't comment. Doctors won't comment.
Doctors
and that's what I want to talk about.
The reason they don't comment perhaps is because as things stand in the UK, they are novel foods. Okay, so they do not have. You're not allowed by law or through our guidance say that this for example, you say take that product because it might help your pain, or you could get yourself hot water as a doctor. However, what you can say, and I actually wrote a guide for clinicians for CBD. If you go to the UKMCCS.org, UK Medical Cannabis Clinician Society, we're a group of specialists and doctors, and we put our own guidance out. And I actually wrote the CBD publication, and it's about understanding CBD, how it works, how it might interact with some of the other prescribed medications, how you have that conversation with your patient. So you can talk about how it could improve wellness or general well-being, for example, or CBD is a good anxiolytic. It can help with anxiety, with pain, with sleep. So there are ways around it, and I think it's a cop-out for a doctor not to understand what your patient is using, and that applies also, in my view, for our patients that are smoking cannabis to help their sleep or to help their pain. I don't care where they get it from, or I mean, that's a subject matter that we don't get into. It's not our business. But if when the patient's in front of us, we have to understand what they're doing and why they're struggling with something, or what's helping them, what isn't helping them. And I think we need to know everything that a patient's doing and try and help them with it.
So, Dr. Barron, let me just ask you this, but when you go to see your GP, someone like yourself, they say, do you smoke? I don't.
Yeah.
But I'm taking myself out of the equation. They say to the patient or the person sitting in front of them, do you smoke? And then do you use recreational drugs? Do you use drugs? They would say that. So you would have, unless they barefaced lie straight to you in your surgery, you'd have some sort of idea of what they're doing, what they're taking, would you not?
Most of our patients, although some of them don't want it on their records or don't want to talk about it.
Yeah.
I mean, this is another huge subject, but maybe we'll talk about this another time. But there's estimated 1.4 million people in the UK who are using cannabis just for medical purposes.
Exactly.
Well, why do they have to do that? Why are these people forced onto the black market for it? Why don't we regulate it and put it in the hands of doctors?
See, I personally think it's because when a user approaches their doctor to even discuss it, the demonization which is associated with cannabis and the fact that you know, a lot of people within the health system see cannabis as this gateway drug, which causes them so many issues down the line. And what happens is, once again, it's this demonization terminology and this misunderstanding of education and this misunderstanding of terminology and the misuse of the word cannabis. And the fact of the matter
There's huge stigma.
There's a lot which goes on in a doctor's brain when you talk about cannabis with them. So I've got in my family 6 doctors. Okay, one of them's working in California at the moment. She's part of this Nobel Prize research committee. I've got head doctors and GPs and everything based in France. And the conversations which we have are literally, I am a drug dealer. That's basically all they see me as. And they'll turn around to my mum once every couple of months. They'll be like, "Law, you know your son is a drug dealer." And it's not that, because fact of the matter is in France, from a medicinal perspective, cannabis is cannabis, and whether you're using whatever you're using, it's cannabis. And it's a little bit. Sorry.
When I got interested in cannabis-based medicines, a colleague said to me, first of all, he said it was snake oil, and then he said, "Careful what you'll get. It sounds like legal drug peddling to me." That was the
exactly
that was the initial thing. Look, we've all had.
Still think that they still think that. So what do we do?
Look, when you go through medical school and you train in your specialties, most of us have done psychiatric placements. We've all seen those patients with psychosis who have been triggered by high THC. The street cannabis is very, very high in THC. It's skunk. Essentially, it's skunk. Very high percentages. Probably about 5 times stronger than in the 60s when people were smoking pot back then. So if
but it's exactly the same as the medicinal products which are being used in California.
Exactly. So if you've got a predisposition and you have a genetic predisposition, or you're using it in adolescent, yes, high THC can be it can be detrimental and can occasionally cause episodes of psychosis. So that is, you know, for that reason, yes, you have to be very careful with that particular cohort and those sort of products. But you know, so a lot of doctors have only been taught that, or they've only seen that. And unlike the poppy plant, the opium and other digoxin, you know, loads of other medicines that we prescribe that come from plants, cannabis has a huge stigma around it. You mentioned cannabis, and it's met with, I can tell you,
heroin is absolutely fine. But
cannabis has been manipulated. It's been politicized over the last 50 or so years, particularly in the US. I mean, and that's really what we're fighting at. If cannabis was called, you know, alpha, beta, something else, do you think anyone would care as much about doctors prescribing this?
No, they wouldn't, because it comes with a whole load of baggage. Let me just answer this question to Maureen Corona. Probably not the best name to have at the moment, but I bet everyone said that to you. Oliver, what's the name of your site? It is the Tincture Club. So if you just go online, Maureen. Say that again?
Yeah, I said, don't forget to put in your Men's Radio code, your Men's Radio 10. It gives you your 10% discount on the product.
That's right. So when you're checking out there, put in Men's Radio 10 and you get your automatic discount. Marvelous. Leon, Dr. Barron, something that is...
Go on, can I ask a question?
No, because I was about to. Do you think it's ever going to be destigmatized? Because it's a huge issue.
It's slowly happening. I mean, I think if you look at in North America to cannabis, it's changing, and people across the ages are using it and finding benefit through it. You know, in Israel, let's go to Israel for a second, because they've been researching it for years and years. They've not had the same attitude for it on an academic level. And, you know, you talk to people over there, patient, everyone knows someone who's using a cannabis script or who's got an oil or this. And we're just a little bit behind here. I think we've just got this slightly old-fashioned sort of slightly inward-looking approach to it. And unfortunately, the result of that is patients are missing out on what could be very effective treatments. But I think we've got a long way to go.
I've got to do this. Sorry, I must, on behalf of Men's Radio, I want to apologise to Chrissy Holt. There was a light-hearted mention about heroin, and as she said, with heartbreaking honesty, my daughter, because of lockdown, is now a heroin addict, no work, etc., and it's destroying me. Chrissy, we wish your daughter well, and you know that on behalf of Men's Radio, because you've been so loyal and so supportive since day one. We send you our very, very best.
I'm really
It was
sorry.
just it was a throwaway remark. Please don't take offence. Ollie, you had a question for Dr. Barron.
Yeah, so doctor, you've got 5 minutes left, and what I want you to do is basically tell everyone what you're trying to achieve, because I feel like we haven't actually talked about what you are actually trying to do, and it's so important with these GPs and everything. I just kind of want to get everyone to kind of support you and your plan to try and re-educate.
Okay, so fortunately, there's quite a few doctors out there now who share the view that I have, that there's a role for cannabis-based medicines in the UK. There's more and more appearing all the time, actually. So I work with a group called the UKMCCS, which is the UK Medical Cannabis Clinician Society, and we do education. We teach how to prescribe. We get international guests to do webinars for us and so on. I've also set up something called platform called the Primary Care Cannabis Network, ultimately to educate GPs and try and inform them about cannabis-based medicines, how they may help their patients, how we can try and sort of become a unified voice to sort of allow wider access, if you like, for patients. I think we only need about 5% of GPs to understand, who want to understand it to that greater level, who want to learn how to prescribe. And then ultimately, I'd like to see GPs be allowed to prescribe, because at the moment, only specialists are prescribing. And that's a big reason. And that's a big reason why GPs have sort of not been involved in this conversation. And I think a lot of them don't want to get involved because we're not seen as
because you can see how, and to take the obvious example, Leon, like the Daily Mail and all the others would jump on it, and they would, to use Ollie's word, which is right, they would demonize, some GP trying to do the right thing, and they would just demonize them as sort of swivel-eyed.
They need to open their eyes, Russ. I mean, 50 countries plus, 50 plus countries now across the world have legalized cannabis for medical use. If I tell you the majority of the prescribers in the 50 odd countries are GPs. And why? Because we're well placed to oversee treatments. We understand our patients.
Yes.
We could follow them up. We could touch base with them. We can take their, we see the whole picture.
It doesn't cost a fortune as well. That's the main thing.
I do not
the system's there.
Why. Listen, when the law changed 2018 in Jersey, because there aren't so many doctors, GPs can prescribe. And what's happening now? There's few GPs who are starting to prescribe. So why have we had a different approach here? So if you're a patient in the Netherlands or in Denmark or in Luxembourg or in Israel or in Germany, you can go to your GP and you can get a cannabis script if you've got the right, if you fit the right, if you're deemed appropriate and you've been through a thorough assessment. Here we don't. So I guess what I'm trying to do is just to educate. I'm looking to partner with the university. Some interesting talks going on at the moment, but we want to provide high quality teaching. We want people to understand it. We want doctors to understand it and to try and put it into clinical practice. It's going to take a little while, but hopefully, listen, we're gaining momentum and we're slowly seeing a shift. Patients are very powerful as well. Don't forget that. The patient groups,
all about the users.
So for all the Daily Mail negativity, there's an awful lot of positive voices out there, and there's an awful lot of research, good quality research coming out. So we need to look internationally. We need to look at data from overseas and how other countries are doing this.
And now,
so really, that's my patient access.
And right now, the medical system that's actually available in the UK, so these clinics and stuff like that. What are your thoughts on them? You've got a minute and a half.
Well, I think they serve a purpose. It's a good stepping stone to what I hope is wider access. It allows data to be collected. It allows the most in need patients, if they can afford it, to get products. So no, it's good, but I don't really like the idea of a two-tier system. I don't think it's fair.
What do you mean by a two-tier system?
Well, if you can afford a treatment, you can get it. If you can't, you miss out.
But isn't that what happens in the UK with everything? Unfortunately, it's just the medicinal system in the UK.
Well, not necessarily. Not necessarily. If you want a prescription for any other medicine, you don't necessarily need to go to a clinic that only prescribes that type of treatment.
No, but you might have a waiting time of about 1.5 years before they get to see you. So I mean,
true.
back up to the thing of this pain clinics. I mean, what's your other option? Your other option is just sit there and be in pain, or go private.
Or go private. That's
and
two-tier system, isn't it?
Listen, I mean, I've always thought I know I'm aware of time, but if the private market can match the price of the street dealers, I don't know what someone pays a month for their cannabis if they're using it for medical, is £150 a month, perhaps £200. I think if the private clinics can be brought down to those price levels, then they're onto something there. If you can take people off the street and put them give them clean products, clean regulated products.
Unbelievably, and that is a very positive thing. Dr. Leon Barron, yet again, Ollie, you have pulled one out of the hat. What a terrific guest.
Awesome
Terrific.
guest. He'll be
Thank
back.
you
Thanks for
so much. Ollie, thank you very much. Thank you to everybody watching all over the world. Remember, Ollie at the Tincture Club. Bye-bye.
Bye, guys.
Bye-bye.